Psychiatry, pathology, peripartum mood disturbances, ECT, and suicide. All right, so first we're going to talk about peripartum mood disturbances, once again associated with pregnancy and probably the reproductive chapter, but it also goes hand in hand with psychiatry. So first thing you need to know is that there's three separate things. You have postpartum blues, you have MDD with peripartum onset, and then you have postpartum psychosis. Now, once again, the key features here are going to help us differentiate between them is kind of the onset and resolution of symptoms. So for postpartum blues, you're going to have depressed affect. They're going to be very tearful and tired, and it's usually going to start around like a couple days after delivery, okay? Now, the key thing here is that it resolves within 2 weeks, all right? So postpartum blues will resolve within 2 weeks, all right? So usually after 2 weeks of pregnancy or like 3 weeks of pregnancy, they're done with postpartum blues, and that's a very key feature that will help you define what postpartum blues looks like, all right? Next is going to be MDD with peripartum onset, all right? MDD with peripartum onset is just postpartum depression is what it used to be called. And it's the same as MDD. So the symptoms are the same as MDD, but they resolve within 4 weeks, all right? So very, very key here. It's going to meet the MDD criteria with onset either during pregnancy or within 4 weeks after delivery, okay? So same as MDD, that resolves within 4 weeks, all right? Now, treatment here is going to be CBT and SSRIs as your first line. All right. Lastly is postpartum psychosis. Postpartum psychosis is the most rare one of these. And you're going to be seeing like delusions associated with this, hallucinations. They have thoughts of harming the baby or self. So they're suicidal, infantile, and the risk factors are first pregnancy. So if you see like a first pregnancy, then you know that it's postpartum psychosis. All right. And she's saying that she's scared that she wants to murder the child, or she has thoughts of harming herself. All right. You have to immediately hospitalize the patient. Okay. This is the first line treatment. You have to put the patient in some type of hospital to protect the infant and to protect the mother. Okay. Very, very important. That's postpartum psychosis. Remember, it's associated with like hallucinations, delusions, whereas the other ones are not. All right. So postpartum blues is resolving within 2 weeks. MDD is going to be within 4 weeks. And then postpartum psychosis is going to have some type of ideation of suicidality or infantile type of, harming the baby or self. And you have to treat them with hospitalization for postpartum psychosis. Next is ECT, electroconvulsive therapy. This is essentially just going to be shocking a patient. Now, the first line treatment for MDD is going to be our CBT and our SSRIs, but sometimes you can't give that to patients, okay? So especially with patients that have MDD with psychotic features, which is MDD with hallucinations or delusions occurring at the same time, the number one first line treatment for that MDD with psychotic features is actually ECT, which is where they rapidly shock the patient continuously. It induces some type of a tonic-clonic seizure under anesthesia, and it's shown to help their symptoms. So it's very safe in pregnancy in older adults, and it helps with rapid treatment for refractory depression. So that's another cause of it, or another use of it. So if you see ECT as an option, I would rarely ever put it unless they're talking about MDD with psychotic features, or if a patient has continuously like regressed and they have refractory depression, okay, that is not treated with SSRIs or CBT, okay, then you could think of ECT. But otherwise, always put CBT and SSRI treatment. All right, CBT is always first, and then you could try to put them on medication. And if neither of those work and you have refractory depression, you could rapidly treat them with ECT. Lastly, I want to talk about suicide and the risk factors associated with it. So there's multiple risk factors associated that's going to be helpful in question stems. The first one is going to be the male sex. Okay, so males are more likely to complete suicide compared to females. And it's more common in both younger adults and older adults. So it's kind of like a bimodal distribution. Depression is a very high risk factor for suicide, and previous attempt is the number one risk factor for suicide. So if they give you a patient and they start discussing with you their past medical history, and they see that they have a past medical history that's positive for a previous attempted suicide, they're going to ask you and then they're going to give you a bunch of different type of risk factors. They're going to ask you what's the number one risk factor for another episode, and that's going to be a previous attempt. Okay, previous attempt or some type of plan. Those are the two scariest things when we're discussing risk factors for suicide death. Okay, so a previous attempt or some type of plan. They know what they're going to do. They know how they're going to do it. That is a very large risk factor, okay? So one thing that they're going to ask you to do is, what's the most important thing? The most important thing is to protect the patient. So you have to ask about firearm safety in the house. Specifically in the United States, it's the most common method done in this country to complete suicide death. So you have to ask about firearms in the house. And if they do have firearms, you have to remove anything that may cause harm to the patient. Okay, so it's going to say separate the patient from these harmful things that they say in the question step. Separate the patient from the firearms. Okay, that is going to be very, very important. Okay, now I did say something about the male sex. Remember that women try more often to a complete suicide death, but men die more often. Okay, so I just wanted to be clear there about my risk factors. I didn't know if I confused it for you guys. But other than that, remember, protective factors are very, very important, like effective care for comorbidities, medical, familial, or community connectedness is very important. Cultural or religious beliefs is very helpful. And then strong problem-solving skills is very protective, okay? Other than that, remember to remove the patient from anything that can cause them harm. That's something that they like to ask about. And remember that the number one risk factor is suicide attempts previously as well as a plan, okay?